Assalamu alaikum. I am Abdullah Ijaz, roll number 171 on behalf of batch 2, here to present the opening note for our research titled Entrustable Professional Activities in Medical Students, a systematic review. So a lot of the general population around us are not aware what EPAs even are. So just for the understanding, EPAs are basically a set of 13 core activities that the American Association of Medical Colleges, the AAMC, they set this criteria for medical graduates in 2014 that they should be able to perform these minimum 13 activities on their first day of residencies. So like we do have a comprehensive list of these core activities, but just for examples, like like on the first day a doctor must be able to perform a physical exam on his or her patient, or like they should be able to tell the interpret the diagnostic results. They should be able to perform simple procedures like inserting NG tubes and Foley's catheters, etc. So what our paper is about, it's basically about the role of EPAs in undergraduate medical education. There was a lack of in the introduction of EPAs in curricula at the undergraduate level when we did our literature review. So we basically aim to synthesize all that data and integrate it so that further research can be done on this topic at the undergraduate level. So like our research contains a review of 37 total articles. Those are focused on the development, implementation and assessment of these EPAs in undergraduate medical curricula, and most of the results were significant. A lot of them contained statistically significant results, while some did not. Our results do suggest that there is a positive correlation between the use of EPAs in undergraduate medical education and better skilled graduates at the end of their sessions. However, there were a lot of limitations in our results as well, there being geographical limitations, language barriers, and a lack of control in the researches that were included in our review, and a lot more that will be briefed further on by the next speakers. So over to the next speaker.
My name is Abdullah Munir Ahmed, roll number 172, and I would present introduction. So, first of all, I would like to define EPAs. What are EPAs? EPAs are discrete units of practice defined as tasks or responsibilities to be entrusted to trainee once specific competence is reached to allow for unsupervised practice. And in simple words, these are the core activities which a student must be able to do unsupervised in his first day of residency, as defined by the Association of American Colleges. And EPAs gave rise to concept of competency based medical education against the traditional time based medical education. In CBME, we take specific milestones as the restraining factor instead of the time based medical education, in which time is the restraining factor, such as our annual systems. And what we saw during our studies is that there is a lack of work done at the undergraduate level, and mostly studies and EPAs are for the postgraduate levels. And so the last thing, our aim, which is to summarize and integrate various studies, as most of the data was scattered, and make suggestions.
Assalamu alaikum everyone, this is Ayman Tahir, roll number 10, and I will be telling you about the methods of our research. So we conducted a systematic review, and this review is in accordance with the PRISMA guidelines as PRISMA flow diagram is shown in the slide. Okay, so talking about the search strategy, we used two databases, PubMed and Google Scholar, for conducting this review. However, in case of Google Scholar, we used the results of first 10 pages only. Moving on towards the selection criteria, only the original research articles and randomized control trials that focused mainly on the development, implementation, assessment, and feasibility of EPAs were included. However, we did not include articles that focused solely on the development of EPAs. Along with that, unoriginal articles like commentaries, editorials, and reviews were not included as well. So for screening, we use Mendeley as a reference manager. Screening was done first on the basis of titles and abstracts, and then full text screening was done. This whole process was carried out by 2 researchers, and the remaining discrepancies were solved by a 3rd researcher. In case of data extraction, the items of data that were extracted included the year of study, the country where the study was conducted, study design, target year of UME, population size, the main area of focus in the respective study, core EPAs discussed, and any specialities involved. Over to the next person.
Assalamu alaikum. My name is Amin Farooq, roll number 7. Let's see study characteristics. We categorized our studies on the basis of name of the authors, years of publication, country from which they were published. 70% of the studies were published in USA, 15% in Germany, and others like Switzerland had 2 publications, Canada, Mexico, and India each had 1 publication. Let's see study designs. 5 studies each involved cohorts, cross-sectional studies, program evaluations, while 3 studies each included the study designs like pilot studies, longitudinal studies, expert consensus, and educational case reports, while case controls, case simulations, and RCTs were the study designs for 1 study each. Main focus of a study is development, implementation, assessment, and feasibility. Most frequently studied characteristic is the implementation of EPAs, followed by assessment, development, and the least frequently discussed is the feasibility. Both development and implementation and development along with the assessment were also studied in some studies. Now let's see target population. Most frequently involved target population was 4th year in 7 studies, followed by final year medical students in 5 studies. 3rd year was the subject of 4 studies, while 1st year and 2nd year was seen in only 1 study each. For the rest of the studies, population was not clearly mentioned. Clerkship specialty. The most frequently found clerkship specialty was internal medicine, seen in 6 studies, followed by emergency medicine in 5 studies, while others like surgery, peds, and psychiatry were seen in 3 studies each. Core EPAs. Most frequently discussed core EPAs out of 13 core EPAs were EPA 1, 2, and 10, while the least frequently studied EPAs were EPA 3, 7, 8, 11, and 12. Thank you.
Ayman Iqbal, roll number 8, the development of EPAs. 16% of our articles are going to focus on the development of specialty-specific EPAs, and 13.5 they're going to focus on the development of an EPA-based curriculum. The specialities we're going to include in our study are emergency medicine, internal medicine, obstetrics, gynecology, general medicine, and surgery. The methods we're going to use are going to be split into 2. The methods we're going to use for the development of specialty-specific EPAs, they're going to include mapping out the core domains and milestones of EPAs, the development of interprofessional training wards. We can also carry out extensive research and review, which is undertaken by a task force of experts. The methods we're going to use for the development of a curriculum, they're going to include workshops, which are based on strategies and for the development of EPAs, and the formulation of models so that we can construct our curriculum around the models we create.
Assalamu alaikum. I am Alina Mujahid, roll number 12. I am here to talk about the implementation of entrustable professional activities in undergraduate medical education. This concept reframes the approach to assessment and competence-based medical education. We have reviewed the literature, and it provides practical recommendations for the implementation process. It provides tips for the clinicians that are supervising the implementation process, and also for curriculum developers. Some tips for the clinicians include talking to the learners about trust, guiding them thoroughly, providing learners with greater ad hoc responsibilities. They should create opportunities for assessment and feedback, and they should acknowledge the gut feelings of the learner if they are ready for more autonomy or not. The curriculum leaders, they should enable trust development and apply the trust decisions at all levels of the supervision scale. They should empower the learners, and they can use technology for tracking the learners and program evaluations. The studies included in the review, They have reported various approaches and methods for the implementation process. Most of these were institute specific. Simulation based training was most frequently used, in which the situations mimicked real life scenarios and the trainees got the opportunity of experiential learning. Some studies have reported the establishment of emergency medical boot camps, some used worksheets to achieve entrustment levels, some established interprofessional training wards. Also, evidence based models for quality improvement process have been established. Individualized coaching by assigned mentors was used. And lastly, EPAs were added in pre existing curricular setups. Of the 37 studies included in the review, 95% have claimed positive outcomes after incorporation of EPAs in undergraduate medical setups. 77% were statistically significant, while the rest of the studies they have claimed positive outcomes but without significant statistics involved.
It's roll number 11, Aiza Hassan. Assessment of EPAs. It's one of the most important inclusion criteria in our research. Assessment of EPAs is the most frequent focus of studies. Studies under this heading are concerned about performing different interestable professional activities by undergraduates and their assessment by using different tools. Frequently used tools are DAVA scale, Chun scale, point-based Likert scale. In this regard, EPA 10 is in focus. Different type of assessment strategies are used. The few important ones are assessment of feasibility of a DAVA scale, mobile technology for workplace assessments, case simulation based on specific clinical scenarios to assess the student situation, and the response to different situations, assessment of students' behavior in emergency situation, patient management, videotaping the student's practical exam and then rating it, physician mentored patient rounds.
Okay, I'm roll number 9 and I'm here to conclude, but first a few points from our discussion. Implementation is the most frequent focus, and the most commonly applied and tested EPAs are 1, 2, and 6. These are history taking, conducting of physical examination, and history presentation. These are the basic skills for medical students. Most of the researchers noted that development of EPAs specific to specialties was quite challenging because a balance must be maintained for medical students between knowing the general skills and the specialty specific skills. For this reason, it's also quite essential. We've noticed that there is no standardized or universal approach for development or implementation of EPAs. Most authors favored modifying pre-existing curricula or pre-existing assessment scales. We also noticed that there are no reliability or feasibility studies for these methodologies. Most of our included studies were centered in two countries only, which are USA and Germany. So these results might not be appropriate for generalizing. Alright, now our main limitations. There was quite a lot of heterogeneity in our studies. We could only search through a limited number of databases, and due to the language barrier, we had to exclude articles that were not available in English. In future, we suggest that there should be greater focus on feasibility evidence and reliability analysis for implementation and assessment strategies. There should be more studies done in larger and more diverse settings, and more studies should be done in underrepresented regions. Lastly, the medical community can learn from the mistakes and challenges we faced while bringing EPAs into the graduate medical education. So the process of bringing EPAs into undergraduate education can go much more seamlessly.